Hi, I'm here with Dr. Kohli, Head of Radiology for Breach Hospital in Mumbai. Thank you for joining me today. So I understand that you use some of our DR equipment, the DRX specifically, the panels. I was wondering, why did your facility need to look at DR in general?
Well, very fundamentally was more from the point of view of turnaround time and ergonomics, in the sense that basically we were using CR, and we were using CR nearly for 10 years since then, because we were one of the first to get into CR, and we were the first to get a DRX panel in the country also. And the reason why we got it was very simple. When a patient came for a chest X-ray, you take the X-ray, you take the CR plate, you put it in the reader, wait till you saw the image, and then you tell the patient, okay, everything's okay, you can go. Whereas with DR, it's so much faster, because you shoot and you see the image instantly. Within 7 seconds, you have the absolutely refined image available. So what would take a patient 10 to 15 minutes is down to now under 3 to 4 minutes. So it's very fast, the turnaround time. And I think today that's very, very important in any workplace, is not only that you got to respect the time of the patient, you got to respect the time of the facility, and today for return on investment, turnover and turnaround time is very, very important. So I think that was a driving force for us to really go for the DRX. Of course, the second point for us to go for the DRX was the portable X-rays and in the ICU, which was probably a bigger problem, because what happens is that you have somebody who's critically ill, you take an X-ray, and the X-ray goes down to the department, to the reader, gets read, printed, and then the image film comes up. We calculated it's anywhere between 20 to 30 minutes, however quick that you move. Now, 20 to 30 minutes in a critical patient can mean a lot, because a lot could have changed in those 20 to 30 minutes. So you're really not giving an accurate representation of how wet the lungs are in a critically ill patient. Whereas with the DRX, we can shoot there, we have a monitor on the machine, and we can see it immediately, the images out there. So it makes, with the DRX, it's made a big difference in the ICU of cutting down the time lag between the time of the X-ray and the image being viewed by the clinician. The second is, of course, much higher image quality. No doubt that DR is a step up from CR. Of course, CR was a huge step up from film screen combinations, but DR is definitely improved image quality, and especially when it comes to areas with the ICU, bedside radiography, where there are a lot of challenges, there's a lot of scatter radiation, there are a lot of issues like that. Any benefit in image quality really improves and helps the clinical evaluation of the patient.
And overall across India, are you seeing more DR being adopted?
Yes. Definitely there are more DRs, but it's still minuscule. I think there needs to be a fairly strong education across the board. Whether it be diagnostic centers, whether it be hospitals, whether hospitals using intensive care, radiography, there needs to be. I don't understand how there can be today an intensive care unit without a DR plate, because it makes such an impact on patient management. And I think there is need for education, and there's need to educate, because unless people know something, they don't think about it. What the eye doesn't see, the brain doesn't know. So it's a simple thing like that, is that I think the message needs to go out. We saw the same thing happening with CR, that the curve on CR was slow, and then suddenly it exploded. So I think the same thing will happen with DR, but with education, you will cut the time lag of the curve when it's on the slope, and the slow slope upwards.
Well, thank you very much for your
Welcome.
time. We appreciate it.